years. Why? Because Perthes disease is more common between 4 and 8 years. That is very important. Why? Because of the difference in the vascular anatomy. You know, yes. Why? Because after 4 years, there is only one vessel, the lateral epiphyseal artery, that is supplying the femoral head. Before 4 years, there are two arteries, the lateral epiphyseal artery and the metaphyseal artery. So what happens at 4 years means there is a physis. So physis is developed, so it will act as a barrier. So it will not allow the metaphyseal vessels to cross the physis to reach the epiphysis. So what happens after 8 years? The medial epiphyseal artery or the artery of the ligament teres will start growing, and that will also supply. So between 4 and 8 years, that is 6 years, only one vessel, the lateral epiphyseal artery. So if there is any kinking of that vessel, that will lead to avascular necrosis of the capital femoral epiphysis. So the answer is Perthes disease. And that is the most common type of osteochondritis. You know what is osteochondritis? That is nothing but the avascular necrosis of the epiphysis, that is the capital epiphysis. And the classical deformity in Perthes disease is flexion, adduction, and external deformity. Whereas, in slipped capital femoral epiphysis, the deformity is actually extension, adduction, and external deformity. So, as I told earlier, the lateral epiphyseal artery is the principal feeder, and that happens between 4 and 8 years. So, here everything is fitting in, and it is associated with an HLA-A1 also. So, there is some genetic predisposition also, low socioeconomic status, then like that. So, there's a genetic predisposition also. So, as I told about the earlier about the vascular anatomy, the most important vessel is the lateral epiphyseal artery, and that is the only feeder between 4 and 8 years. So before 4 years, both lateral epiphyseal artery and the metaphyseal artery, and after 8 years, the medial epiphyseal artery or the artery of the ligamentum teres, that's a branch of the obturator artery that starts growing. So basically, the vessels supplying the femoral head are basically from the deep femoral artery, that's the profunda femoris. So they form a extracapsular ring that's called the extracapsular ring of Craig, and that is the medial circumflex femoral artery going posteriorly and the lateral circumflex femoral artery coming anteriorly. So this is the arterial ring. So in Perthes, something is happening. So in Perthes disease, we see Waldenstrom sign. So here you can see there is a widening of the medial joint space. That is very important, and that is called Waldenstrom sign, and that is classical of Perthes disease. That what is this medial joint space widening? That is due to either a synovial effusion causing medial joint space widening, or that there can be a congestion of the ligamentum teres, or there can be relative hypertrophy of the cartilage, and the bone will not grow, but the cartilage will relatively overgrow. So we cannot see cartilage on an X-ray. So that is why we see a gap here. So more medial joint space binding means the cartilage is normally growing. Why? Because the cartilage is always avascular. It gets nutrition from the synovial fluid and from the metaphyseal perfusion and diffusion. Diffusion from the uh, synovial fluid and perfusion from the metaphyseal vessel. So cartilage will relatively overgrow and the bone will not grow. So that is one of the reasons for Waldenstrom sign. Another reason is synovial effusion. So medial joint space binding is called Waldenstrom sign. So this is another sign seen in Perthes disease where we can see the overlap of the head through the neck, and that is something called the sagging rope. It looks like a sagging rope. That is nothing but the healed stage of Perthes disease. You can see a beautiful sclerotic line over here, and that is nothing but the overhanging head. You are seeing actually the head through the neck, and that is a sign that is described in healed Perthes disease. So that is the radiodense line. And so if you are asked what is sagging rope sign, it is seen in healed Perthes disease. Here you can see the shape of the femoral head is totally flattened, and it looks like a mushroom shape, or it's called a coxa magna or a coxa plana, or a coxa irregularis. So these are all synonyms of Perthes disease. That is coxa plana, coxa irregularis, and coxa uh, irregularis. So, what is the treatment for Perthes disease? The basic principle is containment. That means in Perthes disease, you have to contain the head back into the acetabulum. So that is described by the biology. That is by the Salter's biological plasticity. What is the Salter's biological plasticity means? If you can contain the head back into the acetabulum, then definitely the head can the acetabulum can beautifully shape the head back to the normal, and that is called the biological plasticity by Salter, and that can be achieved by abduction splints. That means how can you contain the head back into the acetabulum? You can abduct the limb and interrotate so that the head will be inside the acetabulum. So here, this is one of the ways of conservative management of the uh, Perthes disease, and that is called a broomstick plaster, or otherwise called a Petri cast. It looks like a broomstick. So here you can see the angle is very important. On each side there is 30 degree, and in total it is around 60 degrees, and the uh, hip is actually in interrotation also. So this is one of the ways of treating Perthes disease. But nowadays we don't go for plaster, we go for surgery, and that is called the varus derotation osteotomy, and that is the treatment for Perthes disease. And the name of the osteotomy is called axis osteotomy. That is nothing but you do actually a subtrochanteric osteotomy where you actually do a varus derotation, means you actually adduct the distal fragment and you externalize the distal fragment. That means relatively the proximal fragment will be abducted and interrotated. That means the head will go back into the acetabulum, and because of the normal acetabulum, it will beautifully shape the head back normally, and that is the biological plasticity. So coming to the next question, a 14-year-old boy is brought to the OPD with a history of painful limbing. In the first question, you have seen it's a painless limbing. Perthes disease is an example of painless, whereas this is a painful limbing, and on the left side. And it's a 14-year-old boy, the age is different, and on general examination, the patient is obese. So the BMI is maybe more than 30, with absence of secondary sexual characters. So definitely there is some hormonal issue. There is loss of secondary sexual characters. You go by Tanner's grading. That means there is definitely hypogonadism. Testosterone will be low. On examination, joint line tenderness on the left hip. So there is definitely a joint line. You know where is the joint line? On the hip joint means it's around 2 centimeters below and lateral to the mid-inguinal point. That is where you palpate for the joint line. And what is the deformity? It is extension, adduction, and extrotation. In the first case, you have seen it is flexion, adduction, and extrotation. So here it is extension, adduction, and extrotation. And with axis deviation. You know what is axis deviation? Axis deviation is a condition where you get a fixed external deformity. That means normally when you flex the hip and knee, the knee actually, normally the knee actually points towards the same shoulder, but you can take the knee to the opposite shoulder. But in a case of fixed external deformity, when you flex the hip and knee, you cannot take the same side knee to the we cannot take the right knee to the left shoulder. So that is a axis deviation. So axis deviation is a condition. Axis deviation means a condition where you get a fixed external deformity. And in this case, there's a true shortening also. So what would be the most probable diagnosis? So tuberculosis of the hip, Perthes disease, monoarticular rheumatoid, or slipped capital femoral epiphysis. So here it's a clear-cut case of slipped capital femoral epiphysis. So, slipped capital femoral epiphysis is actually a misnomer. Actually, it is not the epiphysis that is slipping, it is the metaphysis that is slipping. That means the direction of slipping is very important. The metaphysis actually slips anteriorly and superiorly. So relatively, the epiphysis slips posteriorly and inferiorly. So when the metaphysis slips anteriorly, so what happens? There will be an extension deformity. And when it slips superiorly, there will be an adduction. So the classical deformity is extension, adduction deformity, and external rotation deformity. So that is axis deviation, and because of the slip, there will be shortening also. And classically, a 14-year-old boy, it is common on the left side also. Why? Because majority are right-handed. When you write, you will be putting more counter pressure on the left side, and they say that is one of the reasons for slip. And in boys, it is typically seen between 12 to 14 years, and girls, it is between 10 to 12 years. Why the difference? Because girls attain maturity 2 years earlier than boys. A girl will grow only up to 14 years, and a boy will grow only up to 16 years. So there is a difference of 2 years. And as I told, it is a misnomer, and sleep is actually associated with a lot of endocrine abnormalities. And the most common endocrine abnormality associated with slipped capital femoral epiphysis is hypothyroidism. So remember, hypothyroidism is the most common endocrinological abnormality. Then comes the hypergrowth hormone or a hypogonadism. That means the most common is hypothyroidism. And when you see the patient, your patient will be in a tall, thin. Why? Because of increase in growth hormones and somatomedins. And sometimes the patient will be very chubby with obese with loss of secondary sexual characters, and that is seen in hypogonadism. So there is an association with adipocogenital syndrome also. And when you are asked which layer of growth plate is actually involved in slip, it is a hypertrophic layer. There are different layers for the growth plate. The resting layer, resting cells are there, the columnar cells are there. Then there is a hypertrophic, means there's a maturation and degeneration. And finally, there's a proximal calcification. So actually, it's a layer 3. There's a hypertrophic layer, and that is widened in slip, and that is mechanically weak. So the metaphysis slips over the epiphysis. So here you can beautifully see this is the epiphysis, this is a capital epiphysis, and this is the metaphysis, and actually the metaphysis actually slips over the epiphysis. So here you can actually grade the slip. Actually, a slip is actually graded into you can say less than 1/3, 1/3 to 2/3, and more than 2/3, depending on the displacement of the metaphysis or the epiphysis. So, what are the radiological findings in slip? The earliest finding is actually widening and rarefaction of the physis. That means you will see a widening of the physis with rarefaction. Rarefaction means increased lucency. So remember, widened physis is always, it's a feature of slip, or it may be even seen in rickets also. So there will be loss of epiphyseal height, and there will be widening between the metaphysis and the teardrop also. So a lot of signs are described. The most important sign is this. So you can draw a Trithoven's line. Will show you. Normally, when you draw a line along the superior part of the superior border of the neck, it cuts only a portion of the epiphysis. But here, if you draw a line along the superior border of the neck, this line is not cutting the epiphysis, and this line is called the Kleene line, and the sign is called the Trithoven sign. So what is this Trithoven sign means? You draw a Kleene line, that's a line drawn along the superior border of the neck. Usually it cuts only a portion, but in slip it will no longer cut a portion of the epiphysis, and that is called, so that is one of the earliest signs of slip. And another is called the Capiner's sign. What is Capiner's sign? Normally there's a triangular overlap between the medial metaphysis and the floor of the acetabulum. This is the floor of the acetabulum, and this is the medial metaphysis. So normally there is a triangular overlap between the medial metaphysis and the floor. But here you can see the metaphysis is totally out and the floor is here. So there is no connection between the floor and the metaphysis. So if there is no um, overlap between the medial metaphysis and the floor of the acetabulum, then that sign is called Capiner's sign, or otherwise called sham sign, SHAM, sham sign or Capiner's sign. So what are the signs in slip? Widening of the physis, rarefaction, the Trithoven sign, when you draw the Kleene line, then the Capiner's sign, and another sign is called the metaphyseal blanch sign of steel. That means you can actually see a part of the, so this is the Trithoven sign, and this is the Kleene line. That means normally when you draw a line on the superior aspect, it should cut a portion of the epiphysis, but in slip, it will not. So what is this metaphyseal blanch sign of steel means? Actually, you can see the density of the epiphysis through the metaphysis, and that is called the blanch sign of steel. So what do you do for the slip? The treatment is actually you accept the slip and you go for in situ fixation. If you go for reduction of the slip, that will cause avascular necrosis and lot of complications. So what is the treatment? Is in situ fixation. In situ means you accept the slip and you aim for epiphysiodesis. So here what has been done, you can see a cannulated cancerous screw going through the physis, and it is finally engaging the epiphysis. That means when you put a cancerous screw, these screws, the thread of the screw, that will actually compress and crush the physis, and that will cause premature growth arrest, and that is called epiphysiodesis. So the main aim of slip is premature closure of the epiphysis and further progression of the slip, and that is called in situ fixation, and it's done by a single cannulated cancellous screw. So if you are asked what are the complications of slip, it is avascular necrosis and chondrolysis. Chondrolysis happens when the screw actually goes into the joint, and that can cause cartilage injury, damage, and cause necrosis of the cartilage. So we have discussed osteochondritis of the capital epiphysis, that is called the leg cavipathy disease, and we now discussed about the slipped capital femoral epiphysis. Now we come to another osteochondritis, that's called Sever's disease. So there are a lot of osteochondritis affecting the epiphysis. There are a lot of named osteochondritis. This osteochondritis is actually called the avascular necrosis of the epiphysis. So Sever's disease is actually affecting the uh, calcaneum. So here you can see this is the apophysis of the calcaneum. There are 4 different types of epiphysis. The one type is called the pressure epiphysis. The other is called the traction epiphysis or the apophysis. The other is called the atavistic epiphysis. Example, atavistic means the epiphysis will act as a parasite and on a host. For example, coracoid process on scapula, posterior process of the talus on the talus, like that. So these are all examples of atavistic. Aberrant epiphysis, the examples are um, the metacarpals and metatarsal epiphysis. So here you can see dense sclerosis and fragmentation of the apophysis of calcaneum. Apophysis means traction epiphysis. So this is actually Sever's disease, and that will cause severe pain, heel pain in children. So these are all the named epiphysis. The most important is the leg cavipathies, where it classically affects the femoral capital epiphysis, and Colles disease, it affects the navicular bone. And Kienbock, you might have learned, that is the avascular necrosis of the lunate, and that is very common among people engaged in vibration using machinery, like that. When there is a increased pressure on down, that can cause avascular necrosis of the lunate, and that can cause severe wrist pain, and finally it will end up in arthritis. Then what is this Pricer's disease? Pricer is nothing but the avascular necrosis of the scaphoid. Usually, the blood supply of the scaphoid comes from distal to proximal. So whenever there's a fracture at the level of the waist of the scaphoid, you may see avascular necrosis of the proximal pole, and proximal pole avascular necrosis is actually called the Price's disease. And what is this Sinding-Larsen-Johansson disease? And nothing but the lower pole of patella osteochondritis. Again, that is due to the pull of the ligamentum patella. Then what is this Osgood-Schlatter's disease? It is nothing but, again, an apophysitis or osteochondritis of the tibial apophysis. Then what is this calves disease? Calves disease is nothing but osteochondritis of the vertebral ring apophysis. The ring apophysis is uh, part of the growth plate of the vertebra. So that is calves disease. And what is this Panner? Panner is actually capitulum. That is a avascular necrosis of the capitulum of the distal humerus. And Iceland's disease is nothing but the avascular necrosis of the upper fascia of the base of the fifth metatarsal. So many a time, we may diagnose as a case of Jones fracture. Actually, if you take the history, there will not be any trauma, but on the X-ray you may see something like a separated bone on the base of the fifth metatarsal, and that is called the Iceland's disease. So that is avascular necrosis of the base of fifth metatarsal. And avascular necrosis of the head of the second metatarsal is called Freiberg's disease. So I think you might have now learned almost all the osteochondritis. So each and every osteochondritis is different. And osteochondritis is nothing but avascular necrosis. So next question is, achondroplasia is characterized by all except, achondroplasia, the word itself is self-explanatory. A means no, chondro means cartilage, plasia means growth. So that is the defect in the development of the cartilage. So achondroplasia is autosomal dominant. Lumbar canal stenosis may be associated. Is there any mental retardation? And trident hand. So remember, the IQ will be absolutely normal in achondroplasia, so there won't be any mental retardation. So the answer is mental retardation. And classically, you will see a gap between the ring finger and middle finger. So you can see, like, if there's a gap between the ring and the middle finger, you can see the hand is actually grouped into three parts: the thumb, index, and the middle together, and the ring and the little. So it looks like a trident hand, like a three-column. Okay, and there will be lumbar canal stenosis, that is very important, and there will be decrease in the canal diameter, especially in the lumbar canal, and the interpedicular distance will always be reduced in achondroplasia. And it is an autosomal dominant condition. Even though it's an autosomal dominant, majority are due to sporadic mutation like that. And there is a specific gene called the fibroblast growth factor 3 that is located on the short arm of chromosome 4. So it is located on 4p. So in achondroplasia, it is the most common form of dwarfism, and it is inherited as an autosomal dominant, but majority of the cases are due to spontaneous mutations. So there is a point mutation in the gene that encodes the fibroblast growth factor 3. So the most important protein is the FGF3 that is located on chromosome 4p. P stands for petit and Q for long. Petit in French means short. That is why it is a 4p. And there are three types of dwarfism. One is called a rhizomelic dwarfism. Two is called a mesomelic dwarfism, and three is called an acromelic dwarfism. So rhizo, the word means root. That means proximal part of the limb is affected. That is why short femur, short humerus, like that. So achondroplasia is a classical example of rhizomelic type of dwarfism. That means the humerus and femur are more affected. That means the proximal long bones are affected. And classically, the shape of the pelvis, it looks like a champagne glass. And that's called a champagne glass pelvis because of the peculiar shape. And the radiological hallmark is progressive narrowing of the interpedicular distance. That is why there is canal stenosis, and lumbar canal stenosis is very common achondroplasia. So you can see the typical shortening of even though the trunk looks normal, definitely the shortening of the proximal long bones that ends in rhizomelic dwarfism. So this is achondroplasia. And here you can see there's a trident hand. There's a gap between the middle and the um, ring finger. So it's called a trident hand. So this is the achondroplasia patient. Here you can see definitely the length of the tibia with the femur. Definitely there is shortening of both the femora, and that is a typical rhizomelic dwarfism. And what is Q ankle? The Q ankle is helpful in the diagnosis of recurrent dislocation of shoulder, recurrent dislocation of patella, transverse fracture of patella, recurrent dislocation of temporomandibular joint. So Q, the word itself is important. The Q stands for quadriceps. So it was actually described by a person called Bradstone. It's called a Bradstone angle. The spelling is Brattstor, Bradstone. So it's called a Bradstone's Q angle, and Q stands for quadriceps. Q means the line of pull of quadriceps. So that is useful in the diagnosis of recurrent dislocation of the patella. So what is this Q angle? Q angle is actually an angle found with the line of pull of the quadriceps. That means you take up 2 points, the anterior superior iliac spine and the center of patella. You draw a line connecting these 2 points. You draw another line connecting the center of patella to the center of the tibial tuberosity, and take an angle between these two lines and take the smaller angle, and that's called the Q angle. And Q angle means the line of pull of quadriceps. And in males it's around 8 to 10 degrees, and females it is more, maybe 5 degrees more. So we can say 15 minus plus or minus 5 degrees. So why females are having more carrying angle? Not only carrying angle, Q angle also. Why? Because they are having wide pelvis. So Q angle is actually measured with the knee 30-degree flexion. Why 30 degrees is very important? Because that is the position in which the patella is actually seated on the trochlea, surface of the femur. So when you flex the knee for more than 30 degrees, what is happening to the patella? It starts actually moving from the normal articular trochlear surface, and it gets subluxated. It goes down. So the message is, the more you flex your knee, the more chance of arthritis you can get. So this Q angle is actually measured with a knee 30 degrees of flexion. So this is the Bradstone's Q angle. I told that you draw a line connecting the anterior superior iliac spine to the center of patella. Then you draw a line from the center of patella to the tibial tubercle, and you extrapolate the line drawn distally. That means from center of tibial tubercle to center of patella, you extrapolate and take this smaller angle, and this is the Q angle. It's around 8 to 10 degrees in males and 15 plus or minus 5 degrees in females. So increase in Q angle is seen in genu valgum. That means if the leg goes laterally, definitely the tibial tubercle goes laterally, so the angle will be more. So in increased femoral anteversion also, what is femoral anteversion? The femur actually goes outwards, because normally, what is anteversion? Anteversion means normally, the neck of femur actually is not in line with the coronal axis of the femur. It is around 15 degrees, 10 to 15 degrees anterior to the coronal plane. So when there is excessive femoral anteversion, the femur will be more outwards. So that can again cause more Q angle. The normal anteversion for adults is around 15 degrees, but anteversion at birth is 45 degrees. So as you grow, the anteversion decreases and it becomes the adult 15 degrees. So Q angle is also seen in external tibial torsion, meaning when the tibial tubercle is outward, again the Q angle will be more. Any condition where there is a laterally positioned tibial tuberosity, and when there is a tight lateral retinaculum or a loose or a lax medial retinaculum. So when the lateral tightness is there, then the lateralis, the IT band, definitely the Q angle will be more. So more Q angle means what is the inference? The patella can go out laterally and dislocate. So that is useful in recurrent dislocation of patella. Recurrent means the definition is more than 3 episodes. So what are these iliac horns? Iliac horns, actually they are all radiological findings. You'll be seeing horns on the iliac bone, and that is seen in which condition? Hurley's disease, nail patella syndrome, Albright syndrome, or Engelmann syndrome. It is seen in nail patella syndrome. NPS is a genetic disorder where there is very poorly developed nails and patella. Actually, it is due to an onycho-osteodysplasia, meaning onycho means, nail, osteo means bone. So whenever there is an onychodysplasia, there will be absent nails or very poorly developed nails. And osteodysplasia means Sometimes patella will be very small or even absent. That's called nail patella syndrome. And in nail patella syndrome is otherwise called the iliac horn syndrome or the Fong syndrome or the Turner-Kaiser syndrome. So it is a condition where you see iliac horns. So here you can see beautiful two horns over the ilium, and that is whenever you see two bilateral symmetrical iliac horns, always look for patella and the nails. There will be dystrophic nails and then maybe absent or small patella. And the classical condition is a nail patella syndrome. Then what are these Wormian bones? Wormian bones are actually intersutural bones. Normally I got sutures on the skull. So if there are intersutural bones, they are called Wormian bones. It was actually described by an anatomist, All Worm. And it is seen in a battery of conditions like Down syndrome, cleidocranial dysostosis, fragilitis osseum. So the answer is all of the above. You know what is this fragility? This is a Wormian bone, you can see intersutural bone. And between this sagittal suture and the lambdoidal suture, you can see a separate bone. That's called the Wormian bone. And it is seen in a lot of conditions. And what is fragilitis osseum is nothing but it's a other name for osteogenesis imperfecta. So osteogenesis imperfecta is otherwise called fragilitis osseum or glass bone disease or brittle bone disease, Rollix disease, Lobstein's disease. A lot of names are there for osteogenesis imperfecta. Osteogenesis imperfecta is a condition, where there's a qualitative or quantitative defect in uh, type 1 procollagen. So remember, these are the conditions where you see Wormian bones, pycnodysostosis, where there will be stippled calcification in the bone. Then osteogenesis imperfecta, where you see blue sclera, there will be conductive hearing loss, and that's a classical syndrome called Van der Hoef syndrome, where you see blue sclera or osteogenesis imperfecta plus otospongiosis. There will be conductive deafness. Then rickets in the healing phase also, you may see bones, then kinky hair syndrome, then cleidocranial dysplasia. Cleido means clavicle, cranium means skull. So there will be dysplasia or even absence of clavicle. It's called cleidocranial dysplasia. Then it may be seen in hypothyroidism, hypophosphatasia, then autopalatodigital syndrome, then can be seen in primary acro-osteolysis, then even in Down syndrome, trisomy 21, you can see this Wormian bones. Then what is the Sayles gate? Sayles gate is nothing but a bilateral Trendelenburg gate. You know what is a Trendelenburg gate means? It is a gate seen in Trendelenburg test. When Trendelenburg test is positive, you get Trendelenburg gate. Trendelenburg gate is nothing but a gate in which there's no pain, but the patient is limbing the same side. That means without any pain, the patient will be swaying the trunk to the same side. That's called Trendelenburg. When the patient sways to both sides with lurching to both sides, that is called a Sayles gate. Sayles gate is another bilateral Trendelenburg gate. So that is, Trendelenburg gate is seen when there is a positive Trendelenburg test. Normally, when you stand on one foot, the pelvis on the opposite side will lift. Why? Why? Because the center of gravity should be shifted to the weight-bearing side. Then only the patient will not fall to the opposite side. So for a normal abductor mechanism, there should be a fulcrum, liver arm, and power. The fulcrum is the hip joint, the liver arm is the head, neck, and the trochanter, and the power is given by the gluteus medius, supplied by the superior gluteal nerve. So if any one of these fails, the patient will have a positive Trendelenburg test, and he'll have a positive Trendelenburg gate also. So what are the conditions where you see weak abductor mechanism and Trendelenburg gate? If the fulcrum is gone, or the liver arm is gone, or the muscle is paralyzed. So what are the conditions? You just remember this code BBDDPP. BB means bending and breaking. Bending means bending of the neck of femur. That's called coxa vara. Breaking means fracture, fracture of the head, neck, or trochanter. BB, DD, PP. BB, I told bending and breaking. DD means degeneration and dislocation. Degeneration means the fulcrum is gone. Dislocation means the hip joint, the fulcrum is gone. Then PP. PP means paralysis, polio, and Perthes. So Perthes we already discussed. It is a fulcrum will be gone in Perthes disease because it is a vascular necrosis. Then paralysis means paralysis of superior gluteal nerve with loss of power of the gluteus medius. So these are the conditions where you see positive Tundelbar gate. Okay. So here the answer is actually in bilateral CDH and in coxa vara. So these are the other gate. The most common. What is a limping means an abnormal gait is called limping, and there are a lot of gaits. And the most common pathological gait is actually antalgic gait. That is seen. What is antalgic gait means the patient will walk with the limping with lurching the same side with decreased stance phase. Normal gait means it has got 60% stance and 40% swing. So the patient will avoid putting weight on that side. So that is in osteoarthritis. Most commonly, osteoarthritis is a hip, osteoarthritis is a knee, like that. Then Trendelberg gait, that we discussed fulcrum, liverum, and power in congenital dislocation of the hip joint, coxa vara. It can be seen in fracture of the neck, non-union trochanteric fracture, then paralysis of the superior gluteal nerve, then like that, or even gluteus medius weakness. Then hand on knee gait is seen in poliomyelitis. Why? Because it's quadriceps wasting, and patient will use his hand to lock the knee. Which is the locker of the knee joint. Locker of the knee joint is actually the vastus medialis obliquus. That is called the VMO. And the unlocker of the knee is called the popliteus. So remember, the locker of the knee is the VMO, the vastus medialis obliquus, and the unlocker of the knee is the popliteus. So in poliomyelitis, in the lower limb, the tibialis anterior, the quadriceps will be wasted. And because of the quadriceps wasting, the patient cannot lock the knee, and patient uses the hand to lock the knee. And there will be a impression of the hand on the knee, and there will be some skin color change also in long-standing cases. So what is scissoring gait? Scissoring means due to severe adductor spasm. The adductor muscles will be totally spastic in cerebral palsy, and patient will be having something like a scissoring gait. And what is the high stepping gait means? The patient will purposefully overflex the hip and knee to clear the foot off the ground. That is because of the equine, because of the foot drop, he has to overflex the hip and knee, and that's called a high stepping gait. That is seen in conjunctival palsy. So, what is this hormone teriparatide that is commonly used nowadays? That is used for osteoporosis, not for osteomalacia, only for osteoporosis. So, the teriparatide is actually a parathormone. I think you might have learned in uh, pharmacology. Parathormone is a peptide with 84 amino acids. Of the 84 amino acids, you sequence the first 34 amino acids, and that is the teriparatide. So actually, it is an analog of parathormone. What is the action of parathormone on bone? Actually, parathormone actually causes resorption of bone. That means it causes hypercalcemia. It causes hypercalcemia and hypophosphatemia. It resorbs the bone. Hyperparathyroidism, primary hyperparathyroidism is due to 90% is due to adenoma of the parathyroid gland. And that's a disease of bones, stones, moans, groans, and psychic overtones. That means why it is called as a disease of bone? Because there will be hypercalcemia and there will be resorption of bone. Why there is stone? Because of hypercalcemia, there will be tricalcium phosphate stones in the kidney. That's the Stockholm calculus. Then groans and moans means why there is abdominal pain because of more calcium. There will be peptic ulcer, and that will cause abdominal pain. And why there is psychic overtones, more calcium in the brain means psychiatric problems. So that's a disease of bone stones, groans, bones, and psychic overtones. So that disease is called the von Recklinghausen's disease of bone. So what is this teriparat? Actually, the action of parathormone is actually to decrease the density of the bone. Then why you are giving a parathyroid analog for osteoporosis? Because already in osteoporosis the density is less. But it indirectly it is given every 24 hours. So actually it indirectly stimulates the osteoblast, because whenever there is resorption, it will send signals to blast and that will lay new bone. So indirectly, it is an anabolic drug, because it is given every 24 hours. The dose is 20 micrograms. It should be given for minimum 6 months to 2 years. You should not give it for more than 2 years. And especially if the patient is having Paget's disease, if you give teriparatide, the chance of getting osteogenic sarcoma is very high. So that is proven in rat studies, and you should never give it for more than 2 years. So how will you manage a case of osteoporosis? There are two types of osteoporosis. There's a classification by Ricks and Melton, RIGGS, MELT1, Ricks and Melton, type 1 and type 2. Type 1 is postmenopausal or hormone-based osteoporosis. Type 1 that is classically seen in females. And type 2 is a senile osteoporosis that is seen after 70 years. So, when you treat osteoporosis, actually you have to first start on anabolic drugs like teriparatide, then you switch it over to anti-catabolic drugs like denosumab, like that. Denosumab is also widely used now, denosumab, meaning it's a monoclonal antibody that is targeted against Wrangel ligand. You know what is Wrangel ligand? That is a receptor activator nuclear ligand. So what is a Singh's index? Singh is an Indian orthopedician. His full name is Dr. Manmohan Singh. He is an orthopedician, and he has um, described this index, and that is very useful in actually grading osteoporosis. The gold standard test to detect osteoporosis is actually DEXA scan, the dual X-ray absorptiometry, the DEXA scan, dual energy X-ray absorptiometry. There is single energy also and dual energy. So dual energy X-ray absorptiometry is called the DEXA scan, where you look for density in the Watts triangle in the neck of femur and in the lumbar spine. And normally it should be within one standard deviation. If it is -1, you can say up to -1 is normal. That's the T-score. T-score means you actually compare the bone density of a 70-year-old lady with the bone density of a 30-year-old otherwise normal lady. So normally it should be within -1. If it is -1 to -2.5, it is called osteopenia. More than -2.5, it is called osteoporosis. And as for the WHO definition, what is severe osteoporosis? That is nothing but osteoporosis the BMD more than -2.5 with fracture is called severe osteoporosis. So Singh's index is nothing but you grade into 6 types depending on the trabecular network. There are 5 groups of trabeculae about the neck of femur. The most important is this is the actually the primary tension, and this is the primary compression. The primary compression is the most important. This is the primary compression. It actually comes from the calcar. This is the thickest of portion of the neck, and the posteromedial part, the cortical part. And from there, it's the primary compression trabeculae springs from middle part and goes laterally. And the other group, the primary tension, comes from the lateral and goes medially. And, another group comes perpendicular to the primary tension trabeculae, that is the secondary compression trabeculae. And what is parallel to the primary tension is the secondary tension. And what is in line with the trochanter is called trochanteric trabeculae. So normally there's a primary compression trabeculae, there's a primary tension, and this is a secondary compression, and the secondary tension, and the trochanteric trabeculae. So 5 groups are there. So normally there's a triangle between the primary compression trabeculae, the secondary compression and the primary tension triangle. This triangle is called the Watt's triangle, WARD, where you look for bone density. And there's a small triangle over here that is bordered by actually the primary compression trabeculae, the inferior aspect of the head and the physis, and this is called the Babcock's triangle. This is the triangle where you look for tuberculosis, and this is the triangle where you look for bone density. So normally when you grade, you actually grade from 1 to 6, but in Singh's index, you are actually grading from 6 to 1. This is the other way around. So what is this grade 5? Grade 5 is nothing but only primary compression, primary tension are there, whereas all others are absent or attenuated. Grade 4 means even the primary tension trabeculae are attenuated. Grade 3 means primary tension trabeculae are broken. Grade 2 means only primary compression trabeculae are seen. 1 means even primary compression trabeculae are attenuated. So remember, grade 6 is normal, 5, 4 is osteopenia, and 3, 2, 1 is osteoporosis. So don't forget that. So it's a very simple tool to diagnose osteoporosis. Then what are these Garrod spats? Garrod spats are actually fibromatosis or thickening of the proximal interphalangeal joint, and are very classical of Dupuytren's contracture. What is this Dupuytren's contracture? Dupuytren's contracture is a part of the fibromatosis. That means there is some hyperplasia of the fibrous bands and the palmar aponeurosis, and it classically affects the ring and the little finger. It is seen in diabetic patients, patients with chronic liver disease, patients, epileptic patients, like that. So classically the ring finger and the little finger will be affected, and there will be contraction. And it is called the fibromatosis, and it is associated with actually fibromatosis of the plantar fascia also, and that is called the fibromatosis of the palmar fascia is called the Dupuytren's contracture, because it was described by Baron Guillaume Dupuytren, and fibromatosis of the plantar fascia is called the Ladderhouse disease, and if it is seen in the penis, it is called the Peyronie's disease. So remember, in 3 areas, you call it 3 different names: the Peyronie's disease in penis, the Dupuytren's contracture in the palm, and the Ladderhouse disease in the plantar fascia. So it commonly affects the ring and the little finger. It's commonly seen in patients with chronic liver disease cirrhosis, patients on anti-epileptics, chronic smokers. So if it is seen in the penis, it is called the Peyronie's disease. In the plantar fascia, it is called the Ladderhouse disease. And you may often see fibromatosis of the dorsal PIP joint. That's something called the Garrod nodes of the knuckle pads. So here you can see fibromatosis of thickening of the you can see pads or the PIP joint. They're called the Garrod's pads. And what is this gamekeeper's thumb? Remember, gamekeeper is not associated with any game. It is actually the name of a gamekeeper means actually is a hunter. Gamekeeper means game means the hunting, where they used to kill rabbits by actually snapping the neck. When they snap the neck, they try to tweak the thumb also while doing this hunting. So they will injure the ulnar collateral ligament of the MCP. Why? Because when they try to snap the neck of the rabbit, there will be abduction injury of the MCP joint of the thumb, and that will cause a tear of the ulnar collateral ligament. There is 2 ligaments for the MCP, the radial collateral and the ulnar collateral. When the ulnar collateral is torn, you call it as the gamekeeper's thumb. So what is the stress test? It's nothing but, so this is the uh, ulnar side and this is the radial side, and you just try to abduct the MCP joint by abducting the thumb. There'll be severe pain on the tenderness or the ulnar aspect of the MCP joint, and that's called the stress test. Okay, and this is the uh, gamekeeper's tongue, where you can see the ulnar collateral ligament is injured, and there's a lesion in gamekeeper's thumb called Stein's lesion, where there's uh, the adductor pollicis may get in between these 2 ligaments, and it will not heal. And that lesion is called a Stein's lesion, Stener. It's nothing but the buttonholing of the adductor pollicis into the ulnar collateral ligament. and it's a game. Keeper means nothing to do with the any game. It's a hunter. So what is this Thompson's test? Thompson's test is actually a screening test to detect tendon Achilles rupture. You know, tendon Achilles is the strongest ligament in the human body. Um, Earlier it was called the tendon magnus of Hippocrates. Later, one person called the Philip Verheyen, he only questioned it, the tendon Achilles. So tendon Achilles rupture is very common. It was very common when people used, Indian toilet and all. It was very common, but nowadays we see a lot of closed tendon Achilles. Closed tendon Achilles injury means without any open injury, a forceful dorsiflexion, squatting can cause tendon Achilles rupture. And closed rupture of the tendon Achilles is common in a lot of metabolic conditions like hyperuricemia, dyslipidemia, then inflammatory conditions like rheumatoid arthritis, then collagen vascular disorders. Even it can be a complication following quinolone therapy like uh, lefloxacin, uh, p-floxacin, fluoroquinolones like that. Sparfloxacin. These are the drugs that can cause spontaneous tendon Achilles rupture. And the screening test is called the Thompson's test or the Siemens test. It's nothing but you ask the patient to lie prone and you try to squeeze the most bulkiest portion of the leg. That is the squeeze the calf. Normally, when you squeeze the calf, if the tendon Achilles is intact, definitely the angle will go into plantar flexion. But if there is a tear of the tendon Achilles, when you try to squeeze this muscle, the triceps surae, the angle will not go into plantar flexion. That's called the Siemens test or the Thompson's test. And even without taking an ultrasound, even from the X-ray, you can actually diagnose this injury. And this is, that's normally a triangle called the Kagey's triangle. This Kagey's triangle is nothing but bordered by the posteriorly by the tendon Achilles, anteriorly by the flexor hallucis, and it is inferiorly by the calcaneal superior border. Nothing but it is contained the retrocalcaneal pad of fat or the pre-Achilles pad of fat. And if there is a continuity of a discontinuity of the posterior part of the border of the Kager, that means the tendon Achilles is disrupted. So this is the normal Kager. It was described by Hans Kager. So the boundaries are actually the anterior part of the tendon Achilles, the superior part of the calcaneum, and the flexor hallucis. So but the diagnostic test is clinical, and you can actually do ultrasound to diagnose tendon Achilles rupture. Then what is this Ober's test? Ober's test is actually a test to diagnose IT band contracture. IT band means the iliotibial band contracture. It is commonly seen in poliomyelitis, where when there is a IT band contracture, there will be flexion, abduction, and some exaltation also. So what you do, you ask the patient to lie on the sound side, normal side, and you try to abduct, flex the hip joint. If there is a contracture, you try to allow the hip to fall freely. It won't fall freely because of the tightness of the IT band. It's common in poliomyelitis. Then what is this monophalangeal big toe? Normally, you got two phalanges for the big toe, but if you see a monophalangeal big toe, it's classical of this condition, and that is called the myositis ossificans progressiva, and that is a genetic condition. So earlier it was called myositis ossificans progressiva. Don't confuse it with myositis ossificans traumatica, or other is called the Stern's tumor, STERNER. That is following a trauma and massaging, but this is a genetic condition. It was earlier called myositis ossificans progressiva, but nowadays it is called FOP, the fibrodysplasia ossificans progressiva. It's a very rare condition of the connective tissue, and that's a mutation of the body's repair mechanism, and that will cause sheets of calcification, especially in the paraspinal area, where you see it's dense calcification along the paraspinal area. I can see sheets of calcification, and there will be severe disability, and there can be spinal scoliosis. There can be lot of deformities of the spine, and the patient will have a typical even kyphoscoliosis can occur, and typically the patient will have a monophalangeal pectoral, bilateral monophalangeal pectoral. So monophalangeal pectoral is a feature of fibro, this myositis ossificans progressiva. So a 20-year-old man a young man was brought to the casualty ER with the history of road traffic accident. He was diagnosed to have a type 2 open. Open fractures are actually classified by Gestel and Anderson. It's very easy. Type 1 means the wound size is less than 1 centimeter, and type 2 means the wound size between 1 to 10 centimeter, and type 3 means more than 10 centimeter. Again, Gestel and Anderson, type 3 A, B, C. A means with adequate soft tissue cover. B means the bone is stripped, means the periosteum is gone, the bone is naked. C means circulation is gone, there is vascular issue. So that is the open fracture classification by Gestel and Anderson. So what is the use of classifying open fractures means type 1 and type 2 can be, even type 3A can be managed by nailing and all, but type 3B onwards you have to go for external fixation. But don't think that the Gestel and Anderson open fracture classification is purely based on the size of the wound. It is based on the grade of soft tissue injury, contamination, and of course the type of, the velocity of injury also. Why? Because if it is a high velocity injury like missile injury, gunshot injury, even if the wound size is less than 1 centimeter, it is graded as type 3. And the duration is also very important. If you see the patient within 6 hours, you can say it is a type 1. After 6 hours, again, he has to label it as type 3. And severe contamination, even though if it is the wound size is less than 1 centimeter, it becomes type 3. And if the underlying bone is shattered, comminuted more than 2 fragments, again, whatever be the size of the wound, it is type 3 only. Again, so this patient is not only having a type 2 open fracture femur, but he's having a blunt injury, abdomen, and a head injury. So he's having a polytrauma. So after stabilizing the vitals of the patient was posted in the emergency operation theater for the management of the head and abdominal injury. What will be your orthopedic management? So will you consider traction after thorough debridement? Why? Because it's an open fracture. It's a type 2 fracture. For Gestel Anderson type 1, you wash the wound with, what do you mean by debridement? Debridement means unbridling, meaning removal of the dead and devitalized tissue. So type 1 means you wash the wound with 1 bag of saline. 1 bag means 3 liters. Type 2 means 2 bags, 6 liters. Type 3 means 9 liters. So remember, for type 3, you wash it with 9. Type 2, 6 liter. Type 1, 3 liters. So upper tibial skull retraction after thorough debridement. External fixator application after thorough debridement. Interlocking nail for the femur after thorough debridement, like plating after the. So here we cannot go for nailing or plating. Why? Because the patient is already down with head injury and abdominal injury. So here the treatment is actually damage control orthopedics, and that is called DCO. So you can say there are 2 types of management: ETC and DCO. ETC is actually early total care, and DCO is damage control orthopedics. So early total care means when the patient is admitted to the ER, the very next, on the day itself, you go for early total care, means you do nailing and you do the definitive procedure. But if the patient is having a polytrauma, don't go for early total care. You go for damage control orthopedics, because your surgery, already the patient is having a first hit called the trauma. Your surgery is another hit, that is called double hit hypothesis. Whenever there is a double hit, the patient will develop multi-organ dysfunction, patient will die. So to avoid that, you don't want to damage the patient. So damage control orthopedics is nothing but you apply external fixator, you do delay the definitive procedure, and later you switch to nailing later. So a open fracture with polytrauma and all, you go for external fixator only. Otherwise, even up to type 3A, you can go for nailing, provided there should not be any head injury or abdominal injury. So in this patient, you go for damage control orthopedics. So remember about two terms, the early total care and damage control orthopedics. If there is no polytrauma, you can go for early total care, the definitive fixation like nailing and all. But the patient is having polytrauma and all, you don't have to cause damage, and otherwise the patient will die of molds and multi-organ dysfunction and all. So go for damage control, meaning you go for external thorough WMA external fixation. You wait till the inflammatory mediators are subsided, and you go for the definitive procedure later. So remember, this is the double hit hypothesis, two hit hypothesis. The first hit is your road traffic accident or the trauma, and your surgery is another second hit. If it is not actually in polytrauma and all, if you go for surgery and all, patient will develop ARDS modes and patient will die. So what is this aeroplane splint? Aeroplane splint means like the wings of an aeroplane. You keep the shoulder in abduction. So that is used in Erb's palsy. Erb's point is nothing but where six nerves meet. Actually, the C5 and C6, it is actually clinically at the anteroinferior part of the neck. That's the Erb's point where 6 nerves meet. The anterior, the ventral primary ram of C5, C6, their anterior and posterior divisions, and two nerves, that is the suprascapular nerve and the nerve to subclavius. These are the 6 nerves that meet at the Erb's point. So Erb's palsy C5, C6, the upper trunk injury, where the typical attitude is a policeman or a waiter waiting for a tip, where the shoulder will be adducted, the elbow will be extended, the forearm will be pronated, and the wrist will be flexed. And why this deformity? Why? Because of C5, C6, the upper trunk palsy. So that is upper trunk means the C5, C6. You should learn about myotomes. C5 is responsible for shoulder abduction. C6 root is responsible for elbow flexion and wrist extension. Whereas wrist flexion and elbow extension is by C7, understood. And thumb extension is by C8, and movement of fingers is T1. And supination is also by C6. So if C5 and C6 are gone, loss of abduction, loss of flexion of the elbow, and loss of extension of the wrist, and loss of supination. That is why you see the policeman, the typical attitude of a policeman waiting for a tip. So there will be, you can give aeroplane splint to keep the shoulder in abduction, so to prevent adduction, interrotation contraction and all, you give this aeroplane splint. And Erb's palsy, it is very common following shoulder dystocia and all when the birth weight of the babies, following delivery with the birth weight of the baby is more than 4 kilos. So remember, when the birth weight is more than 4 kilos, the chance of shoulder dystocia is there, and that can result in Erb's palsy. So what is this gallows traction? Gallows means, like, the word itself means like a gallows that is being hung. So that is typically given for fracture shaft of femur in infants. So this is an example of a gallows traction, and it is typically given for fracture shaft of femur, and that is done only in infants, because after 1 year there can be decrease in the vascularity of the distal part of the limb, so we don't go for gallows splint after 1 year. And one more thing to add, when you give this traction, the buttock should be elevated. Otherwise, there won't be any counter pressure. There will not be any counter traction. So this is given for fracture shaft of femur. This is another traction called the Dunlop traction that is given for supracondylar fracture of the humerus. When if the patient is having severe impending compartment syndrome, severe blister and all, it's a delayed case of supracondylar fracture. Definitely go for Dunlop traction, so that you can actually, given an extension type of supracondylar where the distal fragment goes in the posterior compartment and the proximal fragment goes into the flexor, so you can actually correct the displacement by this Dunlop traction. So these are some named fractures. These are actually stress fracture. What is the difference between stress fracture and insufficiency fracture. A stress fracture means abnormal stress to a normal bone is called a stress fracture, whereas a normal stress to an abnormal bone is called a insufficiency fracture. So what are the causes of a insufficiency fracture is actually osteomalacia, osteoporosis, like that. But here, these are all stress fracture means the bone is normal, but abnormal stress. So what is this March fracture? March fracture is actually second metatarsal fracture that is normally seen in army and police recruits where when they march for long distance and all, there will be stress because of abdominal stress causing fracture of the neck of the second metatarsal. Then clay shoveler. Clay shoveler is seen in manual laborers when they shovel the clay, and causing sudden flexion and extension, and that will cause the pull of the ligamentum nuchae, and it will pull the C7 spinous process. That is called clay shoveler. So clay shoveler is actually a avulsion fracture of the spinous process C7. And runner means actually the lower third of fibula fracture is runner. Jumper means an upper third. And the ballet dancer is a mid shaft. The dance is fracture. So here you can see actually a march fracture. But when you see a stress fracture, always rule out osteonic sarcoma. That is very important. Especially in the long bones, when you see a healed stress fracture, always think of osteonic sarcoma also, because osteonic sarcoma can be a DD of this stress fracture. Okay. Then the most common cause of a pathological fracture. You know what is a pathological fracture? A pathological fracture means a trivial trauma, low energy trauma causing fracture in an already deceased bone. Low energy means just getting out of the car or getting out of the bed or even fall from a standing height. These are all low energy fractures. And the most common cause of a pathological fracture is not metastatic bone disease, it is osteoporosis, because something like an ubiquitous disease is the most common cause of a pathological fracture. That means all the neck of femur, all the trochanteric fractures in elderly are all pathological fracture. Whereas metastatic bone disease is actually the most common malignant bone tumor. So most common malignant bone tumor is metastatic bone disease. Most common primary malignant bone tumor is actually multiple myeloma, then followed by osteonic sarcoma, then Ewing sarcoma, chondrosarcoma, like that. What is this gunstock deformity? Gunstock means it looks like the loading stock of an old-fashioned double-barrel gun. And that is called the gunstock deformity. That is called cubitus varus. That is seen in malunited supracondylar fracture of humerus and also in medial epiphyseal injury. You should know about the line of growth of epiphyses. It always grows in an opposite direction. Medial will grow laterally and lateral will grow medially. So if there is an arrest of the medial epiphysis, the lateral will grow medially. So that will result in cubitus varus. So the answer here is malunited supracondylar. Malunited supracondylar means 97% of the supracondylar fracture. The classification is Gartland classification. 97% extension type, and only the 3% is flexion type. And if you take the extension type, the most is common is the posteromedial part. That means the distal fragment is displaced posteriorly and medially and internally rotated. So supracondylar fracture happens in 3 planes: the frontal plane, the axial plane, and the coronal plane. So answer here is both A and B. Because if there is a lateral epiphyseal injury, the medial will grow laterally. That will result in cubitus valgus. So remember, lateral epiphyseal injury will result in cubitus valgus, whereas medial epiphyseal injury results in cubitus varus. So I told about it's a loading stock of a old-fashioned gun, and this is the cubitus varus. Normally, you've got a carrying angle of around 5 to 10 degree in males and 10 to 15 degree in females. Again, the carrying angle is more in females because to accommodate the wider pelvis. And what is carrying angle means the angle subtended between the line connecting the axis of the arm and the forearm, and the elbow is kept in actually in full extension and forearm in full supination. So this is an example of a cubitus varus and is an example of a cubitus valgus. Cubitus valgus can cause tardy ulnar palsy. So tardy means late onset. So it can cause traction injury to the ulnar nerve. So cause of cubitus valgus, most common cause you can say it is non-union in the lateral condyle of the humerus, then lateral epiphyseal injury as I told earlier, then very rarely posterolateral type of supracondylar fracture of the humerus, because most common type is posteromedial type, causes cubitus varus, and bilateral cubitus valgus you may see in Turner syndrome. That is nothing but patient streak ovaries exo syndrome. So, tardy ulnar, tardy, the word means late onset. It's a traction in type of injury, and that goes stretching of the ulnar nerve. And the treatment for tardy ulnar nerve palsy in cubitus valgus is actually anterior transposition of the ulnar nerve. That means you transpose the ulnar nerve anteriorly so that it can escape from this traction. Then Steinman pin is used in the skull traction in all sites except, Steinman pin nowadays we seldom use, only for patients waiting for surgery. You may give a skull traction and BB splint, bowler bronze splint, and it can be used in upper tibia, lower tibia, greater trochanter, can be used in calcaneum, but we don't use in fibula. Okay. So this pin is called the Steinman pin. It was described as Fritz Steinman, and this stirrup is called the bowler stirrup. And the patient is actually will be on a BB splint, bowler bronze splint. Not only that, for close reduction of the long bones also we can use this Steinman pin and bowler stirrup. This is a fracture table where you can go for close reduction internal fixation. For that you need to put a Steinman pin and bowler stirrup. What is the Shooter-Workman's law? A lot of laws are there in orthopedics. Shooter-Workman's law is actually related to cartilage, meaning whenever it was described by Richard Workman, the same man in 1881, he described Workman's contracture also, VIC, Workman's ischemic contracture. So, the basic principle is compressive force inhibit growth and distraction or the tension will stimulate the growth. It's simple. So when you compress the cartilage, the damage is done and growth will not happen. But when you give a distraction, you give traction, tensile force, it will stimulate. So that is the basis for Blount's disease, male lung deformity, everything. That means when the middle part of the growth plate of the tibia is compressed, the middle will not grow, the lateral will overgrow, and that will cause tibia vara. That's called Blount's disease. And what is this Wolff's law? Julius Wolff, in 1901, he published his famous paper in 1901, and he described Wolff's law related to bone. That means the bony trabeculae are laid along the line of stress. That means more the stress to the bone, more new bone formation. What is the stress to the bone means? More muscle pull. So the take-home message is, if you want to have good bone stock, there's no point in pumping in calcium additives alone. You have to combine it with exercise. That to contact aerobic exercise. That will put more stress to the bone and more new bone formation. And when you don't use your joints or muscles for 3 weeks, you will get decalcification of the nearby joints and bones, and that is due to pseudox osteodystrophy. Again, that is explained by Julius Wolff's law. That means you are not using means it will be patchy osteoporosis or regional osteoporosis, or otherwise called salt and pepper appearance. That is in pseudox osteodystrophy. That is a part of the fracture disease where the patient won't mobilize or use the limb. And what is this Lifford-Wagstaff fracture? Lifford-Wagstaff fracture, it classically affects the lateral malleolus. It's actually a pediatric injury where, due to an avulsion of the AITFL, that's called the anterior tibiofibular ligament, anterior inferior tibiofibular ligament. It is attached to actually the anterior tubercle of the fibula and into the anterior part of the tibia. But in children and all, the ligaments are very lax and elastic, so it won't be torn that easily. So it comes with a piece of the cartilage and bone, and that's called the Lifford-Wagstaff fracture. And if it comes with the part of the tibia, it's called a Tillaux fracture, Tillaux. So if it is from the tibia, it's called a Tillaux fracture. If it is from the fibula, it's called Leaford Wagstaff. So, in children, a Tilloch fracture, it was described by Paul Tilloch. It's basically a Salter-Harris type 3. You know what is Salter-Harris? Salter and Harris, they classified epiphyseal injuries. Type 1 means nothing but it is an epiphyseal-metaphyseal separation. Type 2 means where you see a flag sign or a Thurston-Holland sign where there is a triangular shaped injury to the metaphysis. Type 3 means injury to the epiphysis only. That means injury to the physis extending into the epiphysis. Type 4 means actually injury through the physis extending into both epiphysis and metaphysis. Type 5 means local crushing of the physis. So, the most common type of Salter-Harris is type 2, where you see the Thurston-Holland or the flag sign. And type 5 carries the worst prognosis by because crushing of the physis. And Tilloch's is a type 3, meaning it's an injury through the physis extending into the epiphysis. So, most common site of bipartite patella. Patella is actually ossified from numerous ossification centers, and the blood supply is from inferior to superior. If some one or two ossification centers, they fail to unite with the normal patella, then you will see it as a separate piece of patella. And the most common, and it is often diagnosed as a patellar fracture. But how will you differentiate from patellar fracture? In a fracture, the edges will be very sharp and angulated. But in bipartite, since it is a developmental problem, the ends will be rounded and very smooth. And the most common location is suprolateral. Very important is suprolateral. And 80% of the cases are suprolateral. And if you see a case of bipartite patella, remember 50% are bilateral. So here you can see a beautiful supralateral. So bipartite. Sometimes it can be tripartite also, 3 parts. So it is classically seen on the supralateral part of the patella, 80% in the supralateral and 50% are bilateral. Most common causes of recurrent dislocation of patella. We already discussed about Q angle. The most common risk factor is patella alta. What is alta means? High riding patella. So there is an index called the Insult-Salvati index. You divide the length of the patella by length of the ligament. This is the length of the tendon by length of the patella. So if you divide by LP by LT, it should be normally 1. But then patella alta means if the patella is riding high, that means if the length of the ligament of patella is very high, very more, then LP by LT will be less than 1. So that is called the patella alta or the high riding patella. So that is a very important risk factor for recurrent dislocation of patella. So these are the common factors predisposing recurrent dislocation of patella. The first one, the top on the cards is patella alta, then genu valgum, so that the Q angle will be more, so the patella will go laterally. Then hypoplasia of the lateral condyle of the femur. That means if the lateral condyle is hypoplastic, then the patella cannot usually sit on the lateral part of the articulating surface and it will dislocate laterally. And very tight structures on the lateral side, like tight vastus lateralis, IT band contracture, like that. Then lax medial structures like medial retinaculum is lax. Then external tibial torsion, and then excessive femoral anteversion, like that. Then Fairbank's test is used in the diagnosis of Fairbank, a lot of Fairbanks in orthopedics. Fairbank's disease is multiple epiphyseal dysplasia. Fairbank's triangle is actually seen in the congenital coxa vara, and Fairbank's triad is there. Triad means 3 things. They're actually seen after meniscectomy. There will be osteophyte formation, osteoarthritic changes in the knee, and that is described by Fairbank. And Fairbank test is actually a static apprehension test done to detect recurrent dislocation of patella. And what is the test? You keep the knee in 30-degree flexion and try to subluxate the patella laterally. If you can dislocate the patella in 30 degree of flexion, then it is a positive apprehension test. And this test is called Fairbanks test. So remember, this is static test. But nowadays, we don't do this test. We do this test, but it's not that specific. The most specific and sensitive test is Ahmed's test, where you do the moving patellar apprehension test. That means you move the knee from extension to flexion, and in the first phase, you try to push the patella laterally. In the first phase, the patient will be having pain and they'll feel apprehension. In the second phase of the test, you keep the knee moving from extension to flexion, but you try to push the patella medially. So in the second part of the test, the patient will have relief of pain, and because you are pushing the patella medially, and that's called a Hammett's test, and that's called a moving patella apprehension test. So if you are asked, the most specific test is not static test or the Fairbanks test, it is the moving patella apprehension test. So this I told, the Fairbanks disease is multiple epiphyseal dysplasia. Triangle is seen, Fairbanks triangle is seen, congenital coxa vara. That's a growth defect in the inframiddle part of the neck. That means if the inframiddle is not growing, means the lateral will grow medially and the patient will be coxa vara. Coxa vara means when the neck shaft angle is less than 110 degree. Coxa valga means when the neck shaft angle is more than 150 degree. Coming to osteochondritis dissecans, well, the most common site is actually medial femoral condyle, meaning the attachment of PCL. Only 10% of the cases affect the patella. So the etiology of OCD, the osteochondritis dissecans means, what is osteochondritis dissecans means? It's loss of blood supply, and that will cause a loose fragment of the osteochondral fragment in the knee, and that may present as a loose body also. So it is more commonly, 70% of the cases are seen in the middle femoral condyle near the PCL attachment, 20% in the lateral femoral condyle, only 10% in the patella. So almost 80% in the classical location in the PCL area, less than 5 in the patella, and 15% in the infracentral part of the lateral femoral condyle. So here you can see a loose fragment in the knee, and this is typically diagnosed only by a notch view or a flexion with bearing view, or otherwise called the Rosenberg's view, Rosenberg. And this view is taken with a knee 30-degree flexion, and a PA view is taken. And you can see the loose fragment. This is classically at the PCL attachment site. And this is the OCD, osteochondritis dissecans. So you can see a part of the bone and the cartilage is avascular, and the treatment is actually you can drill, you can do micro drilling, and you can even do OATS. OATS means osteochondral autologous. You can transfer a non-articulating piece of the cartilage and the bone, and you can transfer here. Osteochondral transfer can be done. Then reconstruction nail used in the management of. Whenever you see a case of fractured shaft of femur, always rule out ipsilateral neck also. Why? Because usually you may overlook a neck of femur in a shaft. Around 6 to 12% of the cases, the shaft of femur is associated with neck of femur. So you have to address both the fractures together. In that case, you can use a reconstruction nail. So here you can see a reconstruction nail means you, through a single implant, you can address both the neck as well as the shaft. Nowadays, we can use even proximal femoral nails also. Then flowing intervertebral ossification is seen in ankylosing spondylitis, Forster's disease, osteopetrosis, all the above. So here the answer is flowing, like flowing wax. It is seen in Forster's disease. It's nothing but a dish. It's nothing but a diffuse idiopathic skeletal hyperostosis, where you see there will be flowing wax, like a lot of calcification, bone deposition, spurs and bridges in the ALL, anterior longitudinal ligament, and that's called the Forster's disease. Here you can see a lot of ossification in the anterior longitudinal ligament, and this is called the dish. This is a case of bamboo spine, where you can see a poker's back or you can say severe kyphosis, and very severe case you can see chin down chest deformity. This is a classical case of ankylosing spondylitis, where you see bamboo spine, and you can see syndesmophytes building the vertebrae. And when a lot of signs are there, you should remember about bamboo spine, dagger sign. You know what is dagger sign? Dagger means when there is uh, calcification, ossification along the spinous and interspinous ligaments. It's called the dagger. Like dagger means kadara പോലെയിരിക്കുന്ന. Then you can also see syndesmophytes, and you can see bamboo spine. Here you can see bamboo spine and tram track calcification are like calcification along the syndesmophytes and along the supraspinous interspinous ligaments. So remember about bamboo spine, uh, this dagger sign and all. Okay. In ankylosing spondylitis. Ankylosing spondylitis is associated with B27 also. Then congenital pseudoarthrosis of tibia is associated with. Pseudoarthrosis means, false joint. And there will be a gap between the two bones and it will never unite. And congenital pseudoarthrosis is nothing but it is associated with fibrous dysplasia and neurofibromatosis. Even there can be intra-osseous neurofibroma. So answer is both A and B. So here is a condition called, congenital pseudoarthrosis is very recalcitrant treatment. Even if you use Ilizaro and all, it may fail because there is a hamartoma, meaning there is a not bone inside the bone, but it could be hamartomous tissue like intraosseous neurofibroma, and that will cause non-union and false joint. So you can see two types of cafe au lait. Here you can see a very jagged pattern, irregular pattern. Here you can see smooth, regular round pattern, and this pattern, smooth round pattern, is called the coast of California, and that is typically seen in neurofibromatosis. Whereas this is a jagged pattern, irregular pattern, and that is seen in that is called the coast of Maine, MAIN. Both are caused in the United States, and this most of Maine is seen in fibrous dysplasia, and this coast of California is seen in neurofibromatosis. So what is this omovertebral bone? Omovertebral bone means, omo means shoulder and vertebra means vertebra. So that's a extra bone connecting the vertebra to the shoulder. That is typically seen in sprangled shoulder. And sprangled shoulder means congenital elevated scapula. That means there's a condition that's normally during the embryonic development, there is a descent of scapula. If that descent is not happening, the scapula will be congenitally elevated. So it is a failure in the early fetal development when the shoulder fails to descend, and it may be associated with clippal feel or congenital block vertebra and scoliosis and all. And this is a classical sprangled shoulder where the shoulder is high and the scapula is high, and on the X-ray you may see an extra omovertebral bone. Here you can see omovertebral bone. You can see. So which of the following is not a packaging disorder? Packaging disorder means the fetus is something like packed inside the uterus, means the intrauterine volume is actually compromised. The examples are oligohydramnios, multiple pregnancies, twin pregnancies, fibroid complicating pregnancy, where the intrauterine volume is oligohydramnios, where it is compromised. So a lot of conditions are grouped under packaging disorder. Only CTV, clubfoot, and there is congenital metatarsus adductus, congenital muscular torticollis, congenital dislocation of the hip joint. So all the four are actually packaging disorder. So answer is none. So the fetus is actually packed inside the uterus and can cause congenital muscular torticollis, congenital dislocation of the hip joint, then congenital clubfoot, and congenital dislocation of the hip joint, and congenital metatarsus adductus also. So wooden doll facies is nothing but expressionless face that is typical of arthrogryposis multiplex congenita. Nowadays, the newer term is MCC or multiple congenital contractures. It is nothing. There are two types of arthrogryposis multiplex congenita. It can be neuropathic and myopathic type, and this condition can be involving the entire joints or only distal part. where, there can be flexion contracture of the hip joints. There will be bilateral dislocation of the hip, bilateral club feet. Then there can be flexion contractures of the knee. There can be even extension of the elbows, flexion of the hand, flexion of the wrist with thumb in hand deformity like that. So it is characterized by multiple joint contractures. Earlier it was called arthrogryposis multiplex congenital. Arthro means joint, gryposis means crooked, multiplex means multiple, congenital means by birth. Now it is called MCC, multiple congenital contractures. So here you can see bilateral DDH, club feet. There can be flexion or even extension contraction of the knee joint. And you can see bilateral extension of the elbow with flexion contraction of the wrist and with typically finger and thumb in hand deformity. It's called thumb in hand deformity. And you can see bilateral DDH, the developmental dysplasia of the hip joint. What is this Bowler's thumb? Bowler's thumb is nothing but perineural fibrosis of the ulnar digital nerve of the thumb. The Bowler's, because they frequently there will be friction of the ulnar digital nerve of the thumb can get fibrosis. So this is the Bowler's thumb, the perineural fibrosis of the ulnar digital nerve of the thumb. Then what is this McMurray's osteotomy? That was a very age-old osteotomy that was done for non-union neck of femur, intercapsular fracture neck of femur, where the shear force, the vertical shear force was converted to a compressive or a transverse force. And it was actually done for neck of femur non-union, but it was also done to relieve pain in osteoarthritis of hip. And this is only for historical importance. Nowadays, nobody does McMurray and all. The principle is you are converting a vertical shear force into compression force, and this is called armchair effect. And that means you do the osteotomy at the level of the subtrochanteric area and displace the medial. So the proximal fragment will be actually sitting on the distal fragment like an armchair, and the line of fracture will be converted into a compressive force and it will unite. Then what is this locking compression plating? LCP. There's an advantage of LCP over DCP is that the minimum contact with the periosteum is there and the periosteal blood circulation is more preserved in LCP, and you can use locking head screws so that even if it can be even in patients with osteoporosis you can use, because the screw will never come out of the plate because it is tightly locked with the plate. Here you can see the difference between the ordinary screw and the locking screw. See, this is the ordinary screw and the locking screw. The locking screw, it has got threads. So these threads will lock with the threads in the hole so that it is a very stable construct. And you can even use unicortical screws. And you just see the undersurface, you can see the undercutting of the plate. So the plate is not actually flush with the bone. There are some areas where there is no contact between the plate and the bone, and these areas, the periosteal circulation is actually saved. So less damage to periosteum for. So here more damage, here less damage, because you can see a gap between the plate and the bone, and the periosteal blood circulation, it accounts for around outer 1/3 of the bone is supplied by periosteum, and inner 2/3 is by endosteum. So that is preserved in LCP. Then just is not indicated in. Just is nothing but Dr. B.B. Joshi, he described this type of fixator, and this fixator is named after Dr. B.B. Joshi. He is actually the first orthopedic student in India, the first MS orthopedic student, and he was a great hand surgeon also. And Bharat Bhushan Joshi, and that is named, this fixator is named after him. He is from Mumbai. So Joshi's external skeletal stabilization system. That's a distracted type of fixator, and that was done for CTV, an intra-articular fracture of distal radius. It is not indicated die punch fracture. So this just actually, the principle is controlled fractional distraction. That means when you distract the ligaments, the bones that are attached to the ligaments will also get aligned back. But die punch fracture is a different die punch. Die means the die in the wrist. It looks like the die means, the die when you play snake and ladder and all, that die. It looks like the bone which looks like the die is the lunate bone. So the die will go and punch the distal part of the radius, and this is the lunate fossa. Lunate fossa is actually quadrangular and scaphoid is triangular. So this die punch is actually, this part of the distal radius is not attached to any ligament. So even if you distract the ligaments, this fragment will not fall back. This you have to open it and reduce it. This is the just fixator used for club foot. The principle I told, it is controlled fractional differential distraction. You distract the medial, more controlled fractional, meaning controlled fractional means you distract in fraction, meaning you distract to the tune of 1 millimeter per day. Or you can say 0.25 millimeter every 6 hours on the medial side and 0.25 every 12 hours on the lateral side. That's what differential distraction. That means you distract both medial and lateral, but medial twice than the lateral. So that why can't you distract only the medial side? Otherwise, if you don't distract the lateral part of the foot will be crushed, and that can cause further growth arrest, and the size of the foot will be less. That is why you distract both medial and lateral, but medial is distracted twice than the lateral. That's called controlled fractional differential distraction. So die punch fracture cannot treated by JES. So JES is indicated in comminuted other distal and radius and clubfoot. So Ender's nailing. Ender is the name of a person. It was used again in the past. We don't use it now. It is used for fixing fracture of. Earlier they used to fix a humerus shaft, tibia, but not ulna. So these are all ender nails. Even we can use it for femur also. So what is this amputation? Gritty stalks. What is amputation? Amputation is the removal of the limb or a part of the limb through the bone is called amputation. Through the joint is called disarticulation. There are a lot of named amputations and disarticulations you have to by heart. Gritty stalk is nothing but a transcondylar femoral amputation. So that is means just above the knee joint you go the transcondylar femoral is called gritty stalk. So here you can see hip disarticulation, above knee amputation, below knee amputation. Regarding below knee amputation, you should know about the length of the stump length. The rule of thumb is for 1 foot of the patient, you have to keep 1 inch. That means if the patient is 6 foot, you have to keep 6 inches. That means 6 inches is 15 centimeter. So 15 centimeters should be the minimum stump length for a 6 foot person. Otherwise, the stump is too short, prosthetic fitment again will be compromised. So Symes is just above the ankle, and Boyd is actually the hind foot. Chopard is actually through the mid-tarsal, that is the talonavicular and calcaneocuboid. And Lisfranc, Lisfranc is the tarsometatarsal joint. I know Lisfranc was the French surgeon to Napoleon, and Lisfranc joint is the tarsometatarsal where there is actually no movement happening. And this is the transmetatarsal and torus articulation like that. What is this Krukenberg amputation? Krukenberg amputation is actually a forearm amputation where actually the patient can actually use these radius and ulna like a chopstick, and they can actually function as a hand. And that is a forearm amputation at the mid forearm level. That's called a Krukenberg amputation. What is a Kramer wire? A Kramer wire is actually a first aid that is used for splinting and transporting victims involved in trauma. That's actually a splint. It is not a used for internal fixation and all. This is actually a splint. It's called a Kramer wire splint that is used to transport trauma victims. Here you can see a supraintercondylar femur being transported using a Kramer wire splint. Then arthrodesis. Arthrodesis is nothing but an intentional surgical fusion of a joint is called arthrodesis. And John Charlie, is the pioneer of total replacement and all. He only described this type of compression arthrodesis. And that is, arthrodesis was once done for even osteoarthritis, for septic arthritis, tuberculosis. Nowadays, we seldom do arthrodesis because even though it's a stable joint, the function is gone. So it was done for knee and ankle. So here you can see this is John Charlie's compression arthrodesis, where you can see you put pins across the bones and you use clamps to tighten the device, and you tighten till the steinman pin starts bending. That is the threshold. So, and you can give beautiful compression of the bones, and that will cause arthrodesis. Compression of the bones means you have to actually denude the cartilage and expose the subchondral bone, bleeding bone. Then only you can compress the joint. Then, what is this mobile wad of Henry? There are 20 muscles in our forearm. Okay, so 20 muscles means actually 8 in the dorsal compartment and 8 in the volar compartment. 8 in the dorsal compartment and 12 in the volar compartment. In the volar compartment, actually 9 in the flexor group and 3 muscles are there in the mobile wad of Henry. So 9 plus 3, 12 plus 8, 20. So mobile wad of Henry is a wad located between the dorsal and the flexor compartment in the forearm, and it houses brachioradialis, extensor radialis longus, and extensor radialis brevis. So answer is not FCU. So ECR, ECRB, and brachioradialis. So for compartments in the forearm, I told about the superficial and deep volar compartment. The superficial and the deep volar compartment total 9 muscles. Mobile wad of Henry 3, dorsal 8. So total 20 muscles. And the most powerful muscle in the forearm is flexor carpi ulnaris. Volume wise and power also, the most powerful muscle is FCU. The muscles paired in lead palsy. Lead palsy, it is it was very common in pain days when nowadays we see lead-free paints and all, but exposure to lead can cause toxicity to nerves, and that can cause wrist drop. But one muscle is typically paired, that is the brachioradialis is paired in lead palsy. So now the markets are flooded with Chinese toys, and they contain lead, and they can cause wrist drop, and paints also cause contain lead, and brachioradialis is typically spared. What is a pseudo fracture? Pseudo fracture, I told, it's an insufficiency fracture. We discussed about stress fracture. It is a stress fracture means an abnormal stress to a normal bone. But a pseudo fracture means an insufficiency fracture. Meaning a normal stress to an abnormal bone is called a pseudo fracture. And it is seen in osteomalacia, in rickets, osteogenesis imperfecta, where the bone is actually weak. But in osteoporosis, it is very strong, but it can break, but it is rock hard. So pseudofracture is seen all except osteopetrosis. So osteoporosis is a different condition where you see rock hard like bone, but dead brittle, and it is due to the disease of the osteoclast. Actually, it is a deficiency of the carbon, and then it's a defect of the carbonic anhydrase. And you will see bone-in-bone appearance or os in os appearance, meaning bone-in-bone appearance is seen in osteopetrosis. And the other name for osteopetrosis is Albert-Schonberg disease. Albert-Schonberg's disease. Then fish mouth vertebrae are seen in all except. Fish mouth is actually meaning biconcave. Biconcave vertebra or biconvex disc. And this space looks like a fish mouth, and that is called fish mouth. But the fish mouth vertebra is actually biconcave vertebra. So that is seen in osteoporosis, osteomalacia, even in sickle cell, but not in hypoparathyroidism. In hyperparathyroidism, you may see weakening and compression fracture of the vertebra, but not in hypoparathyroidism. So these are all typical fish mouth where you can see biconcave vertebra and biconvex disc space. So it looks like the this disc space looks like the mouth of a fish, and it's typically seen in osteomalacia, hyperparathyroidism, sickle cell disease, like that. Then what is this Schauber's test? Schauber's test is a clinical test used to diagnose ankylosing spondylitis. You know, in ankylosing spondylitis, as we discussed earlier, it's a disease, it's a very disabling disease of the spine that affects the young males with HLA-B27 that can cause, we discussed about bamboo spine, dagger sign with a lot of calcification and syndesmophytes and all. So there will be a restriction of flexion, especially when the patient is having kyphosis. So this is the test where you keep the tape around 10 centimeters above the PSIS. This is the PSIS or the dimple of Venus. You know, this is the dimple of Venus correspond to S2 vertebra. You have to know about this is the vertebra pronunciation is C7. The spinous scapula is D3. Inferior angle is D7. The highest point of iliac crest corresponds to lower border of L4. And the posterior superior iliac spine is called the dimple of Venus corresponds to S2. And you know the definition of back is D10 vertebra to S2 is the definition of back. And from DS2 to lower part of the gluteal area, fold is called the gluteal area. So this is the gluteal area, and this is from D10 to S2 is the back. What is above the D10 is the upper back. So you keep a flexible measuring tape around 10 centimeter from the point 10 centimeter above and above the nipple of Venus, and you mark another 5 centimeter down. So you've got 3 points here, and ask the patient to bend forward. If there is around 5 centimeter excursion, that is normal. So remember, 5 centimeter excursion of this test is normal. If it is less than that, that means there is restriction of flexion, and that is seen in ankylosing spondylitis, and that test is called the Schauber's test. I think we can wind up the session. If possible, we can have one more session if time permits. Now I think we can wind up the session. Okay. If you are having any doubts, you can ask. Okay, thank you.